everyone, my name is Minjung Cho. I'm one of the social media section editors of the Archives of Plastic Surgery. I'm excited to introduce APS Hot Off the Press. 2 times a month, we'll be hosting Hot Off the Press with one of the recently published APS authors and 2 panelists. You have a special opportunity to hear directly from the authors and join an insightful discussion between panelists. You can also leave your thoughts as a comment for further discussion.
Hello, everyone. Welcome to the Hot of the Press. I'm Gerke Kim, social media section editor of the Archives of Plastic Surgery. Today's article is Evaluation of Breast Animation Deformity Following Pre- and Subpectoral Direct-to-Implant Breast Reconstruction, a randomized controlled trial. Today, we have 3 authors, Dr. Diana Dyrberg, Dr. Camilla Bille, and Dr. Jørn Thomsen from Odense University Hospital in Denmark. And also we have a panel, Dr. Rocío Perez from National Police Hospital of Peru. She will work as a social media section editor from the 2023. Okay, let's start with the introductory presentation of Dr. Jørn Thomsen.
Yes, I'm Jørn Thomsen, and I'm a consultant plastic surgery surgeon at the Odense University Hospital and an associate professor of the research unit of plastic surgery. So today I'm going to present our latest paper about breast animation deformity. It's called Evaluation of Breast Animation Deformity Following Pre- and Subpectoral Direct-to-Implant Breast Reconstruction, and it is a randomized controlled trial. And this is the paper showing the title and our co-authors. And before we did this, we had some inspiration. I just want to mention 2 people who inspired us over time, amongst many others. The first one is Andrew Salzberg, who presented the acellular dermal matrix for breast augmentation back in 2001, and he published this paper in 2006. And it's his technique that we're using, and we've modified it over time. Another person I want to mention is the late Scott Spear, who published this paper back in 2008 about breast distortion in breast augmented women. Scott Spear was a very innovative and inspiring plastic surgeon. So just want to mention these 2 surgeons. So we published before on this subject, and I just want to mention our previous papers. First, our paper in Archives of Plastic Surgery about breast animation deformity, a systematic review, where we wanted to look at papers where they clearly described how they assessed breast animation deformity. And we looked up more than 1,100 papers, but only 4 of these papers actually described how they assessed breast animation deformity. And these were the papers where there was a clear description of the study and a clear definition of breast animation deformity. But it was quite surprising that there were only 4 papers at that time describing very clearly how they assess breast animation deformity. And just to show you what it's all about, this is before and after activation of the pectoralis major muscle, and you clearly see breast animation deformity. And then we published another paper. It was based on video recordings made by my good friend and colleague, Gudjon Gunnarsson in Norway. He recorded patients who had direct-to-implant breast reconstruction with either subpectoral or prepectoral technique. And what we did in this study, this is just to show the different techniques, but what we did in this study is that we actually developed a new grading scale, the NSE grading scale, for assessment of breast animation deformity. And in this scale, we have 3 entities, one where there's distortion of the skin around the nipple, and one where there's distortion of the skin in the breast. And the 3rd entity is movement of the entire breast, as you can see in this figure. And we subdivided the entities into 3 different, or going from 0 to 2, so you can get a maximum amount of points of 6, or from 0 to 6, as you can see here. And this is how it all started, breast animation deformity. And just to show you what it's all about once again, here's a woman activating her pectoralis major muscle, and you can clearly see that there's breast animation. And another patient doing exactly the same, activating the major pectoralis major muscle, and nothing happens. So this is what we did in our prospective study, is that we compared women who had a subpectoral direct-to-implant breast reconstruction. We compared them to prepectoral technique, and you can see that in these figures here. So what we thought is that the subpectoral, they have thicker tissue coverage over the implant, and they seem to have less capsular contracture. Maybe they have less infection and maybe less implant visibility. However, they probably also have more breast animation deformity, or that was what we were going to look at. And the prepectoral patients, maybe they have less breast animation deformity, less post-operative pain, and maybe quicker recovery. But we didn't know before we started the study. So the bad thing about breast animation deformity is that it is a functional problem. You have muscle twitching, you have pain, and it's more severe in physical active women. And maybe it's also a cosmetic problem, and maybe it has a negative impact on patients' quality of life. And it seems to be worse in reconstructed women compared to augmented women. So the null hypothesis of this study was that there would be no difference between the sub and prepectorally reconstructed women with regard to breast animation deformity. And it was, as I said, a randomized controlled trial. So we included women over 18 years of age who are going to have a direct-to-implant breast reconstruction after skin or nipple-sparing mastectomy. And we excluded those who were planned for radiotherapy or who had radiotherapy, and those who used tobacco or had hypertension who needed more than 2 types of drugs, or if they had breast ptosis with a degree of more than 2. And we only included women who had a BMI between 22 and 32. And of course, those who are not capable of an informed consent could not participate also. So we found 69 patients eligible for reconstruction and randomized 53 to either subpectoral or prepectoral technique. And just to show it once again, here's how we examined the women before and after surgery to assess the breast animation deformity. So we recorded videos of all the women before and after. And we randomized 53, as you just saw, and we ended up having 21 patients in each group after follow-up. And we used the NSE grading scale, as you can see here once again. And we divided the NSA grading scale into mild, moderate, and severe, a simpler way to assess it. And what we found was an average of 3.6 out of 6 possible points in the subpectoral group. That was the average, compared to an average of 0.4 in the prepectoral group. And that was significantly different. And we found 100% breast animation deformity overall in the subpectoral group compared to 23.8 in the or the prepectoral group. And you can see some of the results here. And what's interesting is that all of the 23.8% in the prepectoral group who had some degree of breast animation deformity were all mild. So one could ask oneself, was it really breast animation deformity, or is it the way we assess breast animation deformity that caused these 23.8%? It could also just be rippling, which is more obvious when you activate the pectoralis major muscle, but that's maybe something to discuss. And also, we did a validation study of the NSE grading scale, and we did an inter-rater and intra-rater agreement or assessment using kappa statistics. And we assessed all the videos before surgery and after surgery. And in this validation, we found that there was a total summed agreement of 57%. But when using the mild, moderate, and severe grading, we found an 81% agreement. And you can see how it looks like in the different entities right here. So the conclusion so far from this study is that there's 100% bad in the subpectoral group, and breast animation deformity is significantly lower in the prepectoral group. And the NSE grading scale is reproducible. And also in this study, we looked at pain. We assessed pain in patients on the day of surgery and the 3 post-operative days, and also 3 months post-operatively. And what we found was that there was no difference on the day of surgery, before surgery. However, there was a significant difference in the patient's degree of pain in the 3 post-operative days. However, there was no difference 3 months after surgery. So, what are the perspectives of this? Is breast animation deformity a problem for the patient, or is it a problem for the surgeon, or maybe both? Actually, we assessed this in another study that were the secondary outcomes of this study, where we compared patient-reported quality of life following these 2 techniques and compared these. Of course, the problem with this is that the sample size is not calculated for the secondary outcomes, but it's currently undergoing review at Archives of Plastic Surgery, so we'll see if it gets published. But it's very interesting to see what the patients find after these 2 types of reconstruction. The limitations to this study, of course, is we would have liked a larger cohort. However, COVID-19 did cause some challenges related to this, and we would have liked a longer follow-up. We assessed the patients after 3 months. It would be interesting to see what it looks like after a year, or maybe 3 or 5 years. And of course, as I said, the sample size calculation was based on the primary outcome and not the secondary outcomes. And had the sample size been larger, we could have used maybe the secondary outcomes for more than they are. However, the information for future patients is that subpectoral implant placement is associated with breast animation deformity. However, the levels of post-operative pain should not influence the choice of pocket plane, as there was no difference in pain after 3 months. And the complication rates when comparing the 2 types of reconstruction is similar. And also for future patients, both pocket planes should be offered in shared decision-making with the patients. You have the clinical choice and the patient's choice, and combining these, you have a shared decision-making, and it should be the patient's choice as to what they want. And I just want to thank all of those who participated in the study and gathered data and so forth. Thank you.
Thank you so much for your presentation. I think it's amazing work because you continuously doing the study about the breast animation deformity, and you made a NSE grading system, which is very reproducible grading system. And so the prepectoral reconstruction getting more popularity, and it's kind of like now is accepted as a gold standard for the breast reconstruction. But I think we didn't have any like solid evidence data in randomized controlled study. So that's why I think your work is amazing. Thank you so much. We have other authors from this article. Dr. Camilla, Bille, do you have any comments you want to add?
Well, I think that it is really nice to be able to put the implant in front of the pectoral muscle. You do less harm to the patient. But we need to know if the patients are as happy for the results as we are as plastic surgeons, as Dr. Thomsen also noted that do we want to make the surgeon happy or the patient happy? So we need to ask the patients what they think about the results. That's the most important thing.
Mm-hmm. Thank you. Dr. Diana Dyrberg, do you want to add anything?
Yes, I would like to add that it has been very interesting following these patients because as Dr. Jørn Thomsen said, when we started out, there was very little literature regarding this subject. And even though it is quite obvious that when placing the implant below the major pectoralis muscle, breast animation deformity occurs, then it's no one did really examine it properly with a randomized control trial. So yes, it has been interesting following these patients and also see how it has affected their lives, leading to the more patient-related outcome measure study as well, as Jørn mentioned.
Well, as we mentioned, it all depends on, after informing the patients thoroughly, what the patients want. I mean, if we describe to the patients that if they choose subpectoral, the subpectoral technique, if we describe that it causes breast animation deformity, but maybe it doesn't, if it doesn't bother the patients overall, maybe it's a good technique because you have a better tissue coverage, so it has many advantages. But of course, if it's a woman who does a lot of sports and where we know it's more severe, we would probably make it very clear to the patient that this may be a problem, and then the patient can choose to have a pre-pectoral placement of the implant. But I think right now the tendency is that more and more are going for the pre-pectoral placement of the implant. However, there is a problem with women who have a low BMI and who does not have a very thick subcutis to cover the implant. And the problem with those patients is that they do get more rippling and a more visual implant. So we also have to tell the patients that this is a problem. So actually, we are putting more responsibility on the patients because we can inform them even better now, and they have to choose what they want. Do they want a thicker implant or a thicker tissue coverage, or do they, and breast animation deformity, or do they want a thinner tissue coverage and maybe rippling and no breast animation deformity? I think it's very difficult for these patients because they're in a situation where they have to have surgery, many of them, and still they have to choose between many different things. But maybe Camilla wants to elaborate on this.
Yes, surely I can. Of course, it's always when I do a unilateral, I prefer putting the implant pre-pectoral, but we do have the discussion with the patient. And sometimes I've had a few patients who think they have too much visibility of the edges of the implant and actually come and ask me to put the implant behind the pectoral muscle afterwards. That is a possibility to do that. We have to try to reach what the patient choose from the beginning, but we can change it. And on the other hand, we can also change if we have put the implant beneath the muscle and the patient is very unhappy about the animation deformity, then we can choose to shift the placement of the implant to above or pre-pectoral instead of that. So avoiding the animation deformity. We need to do a lot of shared decision with the patient so that they know what they can choose between, but we also just have to know that the patient they have an idea of what they want, but they don't really know before they have tried it. And if they are very unhappy, then we can change the position of the implant. But if doing bilateral, I will prefer doing prepectoral in most patients, especially in the unilateral, to achieve a cosmetically as natural as possible as a result. In the bilateral cases, if they are very thin, if the BMI is very small, and the skin flaps is very thin, then I would still put it behind the muscle. Of course, after what I have talked to the patients of what they prefer.
Of course, and now that you have this study and these results, it's going to be more clear for patients. Like, you just put it in the table and just give it more options and be clear with the patient. That's great. Perfect. Thank you so much for your answer.
May I just add, putting the implant in the prepectoral plane is not the solution for everything, because we do see that that they get rippling and maybe get thin skin flaps, and some of them also get a larger degree of ptosis over time compared to the subpectoral group. So it's very important that if you use what type of mesh you use, you have to place the mesh precisely right and make sure that it holds the implant in place, so it doesn't slide over time and give the patients ptosis. Because when you get ptosis, you also get thinner skin flaps in the upper part of the breast. So there's, you solve one problem and you cause some new problems. So we still have work to do. And another thing I was thinking as you were talking is that sometimes we choose the subpectoral plane for women who have a very low BMI, but actually what we can do if we place the implant in the subpectoral plane, we have time to do some fat grafting over time, and then we can change the plane to prepectoral. So actually, choosing a plane from the beginning is not a final decision. We can change planes as we want. Actually, it just takes time.
Can I add just one thing? A new method which we have done lately on a few patients, that we take the upper part of we put the implant prepectoral, but make a small slice in the pectoral muscle in the upper part, and just put in the implant top edge beneath the muscle there. So we kind of have a combination of having a prepectoral placed implant, but covering the upper part, the upper edge, only the upper edge of the implant with the muscle, and then you have the benefits from both procedures.
You mean that not only detach the pectoralis major, but just divide the muscle and cover upper part of the implant with the muscle?
Yeah,
that's interesting.
And I also would like to add that as Jørn Thomsen is saying, that we don't know how this prepectoral shift in 5 years. How does the patients look? Do they all have excessive ptosis? Because then we have a new problem. So yeah, we have to see what the future brings.
I want to make sure, what do you mean by the ptosis? So put the implant above the muscle, like a mastectomy patient.
Yeah, what happens is that if the mesh doesn't hold the implant, and if it's not strong enough, then the implant tends to slide down over time. It's kind of like it expands the inferior pole and kind of causes a ptosis, and the pocket actually gets larger and larger, and then the implant slides down, and the upper pole will get thinner, and you'll have rippling in the upper poles actually. So it's very important. It's very important that the mesh is capable of holding the implant in place when you place it in the prepectoral plane.
So you mean the inferior malposition of the implant?
Yes, yes. In other words, yes.
At least we don't know yet.
But why inferior malposition happens more in the prepectoral plane? Because theoretically, even though we do the subpectoral plane, the inferior part along the IMF, we still like doesn't have any same plan. Why is more happening in a prepectoral?
But that's I thought that for a long time, just as you just said it. But the thing is, when you have a mesh covering the whole implant, then the mesh is easily stretched. I mean, you have a mesh covering the whole implant instead of just the bottom. It seems that the mesh is easier stretched when it's a total coverage instead of just the lower pole, because the what do you call it? If it's not as strong, then it's important how wide the mesh is. I mean, the mesh is much wider. The surface is a lot bigger in the prepectoral plane than in the subpectoral plane. So it's easier to stretch the subpectoral mesh because it covers the whole implant. I don't know if it makes any sense to you, but it's that's just what we see. I mean, we don't see it in the subpectoral.
I think that's another study topic. There can be
we could write a paper about that as well.
Yeah. Also, I think an interesting finding is still the prepectoral plan, we have a less breast animation deformity, but about 24% we still can observe breast animation deformity after prepectoral reconstruction. Can you explain more about this phenomenon?
Well, we actually, and Camilla can comment in a minute, I guess, and maybe Diana as well. But we actually discussed that because, when assessing breast animation deformity, we are looking for movement and we are looking for distortion. But what is movement and what is natural movement of the implant, and what is natural distortion? And I think, as at least for my part, once in a while, when I rated it as breast animation deformity, it may have been that the implant was just kind of moving a bit upwards due to contracture in the major pectoralis major muscle, and so maybe it's not a distortion, maybe it's just a slight movement. So it's, we've just developed this NSE grading scale, and we have to get used to using it as well. So what is a distortion and what's not? I mean, I don't believe that when others will be using the NSE scale that you'll find 24% breast animation deformity. I think it will be lower. It's just a matter of we have to get used to using the scale.
And I think maybe also when we assessed, it was on video recordings, and it can be difficult to discern skin distortion from the rippling that can be seen when placing the implants prepectoral. And even though we found this surprisingly percentage, it was also all of them were categorized in the mild category.
I think that if we think about the capsule around the implant, and the capsule is attached to the pectoral muscle in perhaps not 50%, but let's say 35% of the capsula around the implant is attached to the pectoral muscle, then it's quite natural that when you activate the pectoral muscle, then of course you will do some kind of distraction in the capsula, and doing just a little kind of attraction or distortion in the capsula, it is very obvious to see it because the implant is prepectoral and there's not a lot of coverage, but on the other hand, it will always be mild due to that it's not a big contraction of the muscle. So it's just the lower part of the capsula surrounding the implant which is distracted. So it will be mild and seen in a few cases at least, or 1/4 of the cases.
I think that.
We must also remember that the description of distortion and breast animation deformity started out in breast augmented women, and they have a lot more tissue coverage and usually they do anyway, and it wasn't as clear in the augmented women. So maybe this is just the way it is in the reconstructed women, because we expected the percentage to be lower in the prepectoral group, but it could also be this is just how it is. It's different from the augmented group, so we don't know.
I think that's very reasonable explanation. Dr. Rocío Perez, do you want to add anything or question?
Congratulations again. It's a great work. It's teamwork, like I just said. We want more. We want another one.
Well, saying that, we're actually working on another paper from this group. And that's a paper where we compare the muscle strength in the two groups. And we are both looking at the pectoralis major muscle function and if it's affected by the two different techniques, but also the shoulder and arm function. And we're working on that paper. So there's more coming.
Very exciting news. Thank you so much. Again, thank you so much for joining Hot of the Press. Thank you for your time and support for the APS. Thank you.
Thank you.
Thank you.
Thank you everyone for joining us this fantastic discussion. Be sure to tune in for the other article that we'll be discussing on this month's Hot of the Press. You can also connect to Global Plastic Surgery Society through our YouTube channel, Facebook, Instagram, and Twitter. We're looking forward to meeting with you on our APS social media. See you soon.